By the time my guests and myself get onto this set, about 20 minutes before the show, a lot of people have spent a lot of time doing a lot of work. Weeks before the show, our production crew has met several times, done the interviews, created the graphics to tell our story. Every Tuesday at 7:30, our production staff meets to go over what still needs to be done for that week's show, as well as looking to future shows' needs. Thursday morning, the producer Jay and I have a breakfast meeting at a local diner to go over the final tweaks of the show and script. The production crew arrives early to talk about the specifics of the night's show and put the set together. And playback videos are readied, the script is added to the teleprompter, and the graphics are checked one more time to be sure they're correct. Once our guests arrive, they're welcomed into our green room, get a cup of coffee, and are updated about the way the evening will progress. The guests are always gracious enough to answer questions about careers in medicine from our Prairie Doc assistants, or PDAs. These are a group of pre-med students who volunteer to help with various duties for the show. Most importantly, answering the phones when you call in your questions. Once the show begins, the energy of the studio and control room gets a sharp focus. Live television is an adrenaline high. So that's a quick look at some of the things that go on behind the scenes in every production of On Call with the Prairie Doc.
1 minute to air, Dr. Holm.
Well, it's time to go. Enjoy the show.
Arthritis and other joint pain, next on Call with the Prairie Doc.
Good evening and welcome to On Call with the Prairie Doc. As the old Duke Ellington song goes, I don't get around much anymore. Unfortunately for some of us, the reason we don't get around is due to pain and loss of movement in achy bones and joints. Tonight we'll look at the causes of the pain and some treatments that just might help you get around a bit more. First, let's take a look at this week's Prairie Doc quiz question. It's a true or false answer this week. When morning stiffness lasts more than an hour, there is something more than osteoarthritis going on, and you should get in and be seen by your doctor. True or false? Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show, but remember you only have 10 minutes to get your answer in. For the whole show, we'll be answering your questions concerning joint disorders as they're called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send an email to the address on the screen. To help us answer your questions tonight is a longtime friend of the show, Dr. Jim Engelbrecht, rheumatologist, assistant medical director of Dakotacare. I think you've been on the show like 15 times?
I think this is 15.
15?
Right, yeah.
This is the 15th time on our show, so we've been doing this for a few years.
Yeah.
And so as a rheumatologist, your specialty is bones and joints. So what's happened through the years?
Well, I mean, it's been a terrific profession to be in because of the changes in rheumatology. I mean, it has gone from a lot of aches and pains and a lot of inflammation and a lot of disability and a lot of morbidity of bad things happening to people and early mortality to being able to control the disease, manage the disease, influence outcomes, keep people working, productive, enjoying life. I mean, it's a huge change what we've seen in the last 35 to 40 years.
Yeah. What did you used to do for a person with acute rheumatoid arthritis?
Well, rheumatoid arthritis, we've talked about it many times. I mean, part of what I learned to do was to try to teach people to take 16 aspirin a day and then give them gold shots. And then you realize that you'd be successful maybe a third of the time. And just the disability alone from rheumatoid arthritis, back in the 70s and the early 80s, there was about an 80% chance that you would be disabled In other words, not be able to be productively employed or gainfully be employed or have the life you wanted. It was about 80% in 5 years. Now it's completely opposite of that. I mean, the chances, the disease can be controlled in such a way that that 90% of people are functioning normally at 5 years.
I mean, huge.
Huge change, okay? I mean, it's a huge change. And to be part of that over the years and to see the changes of the medications and see the changes in the understanding of the disease process and then how you intercept that disease process safely, it has been an enormously gratifying over the years.
But it's not just rheumatoid arthritis, it's lupus.
Well, lupus, the same, if you talk about lupus in 1975, 1980, when we were in the house, when we were doing our residencies and everything, the 5-year survival rate, once you were diagnosed with lupus, the 5-year survival rate, in other words, how many people were alive 5 years after diagnosis, was like 20%.
I mean,
4 out of 5 were going to die in 5 years once you diagnosed it, okay? Now, the lifespan is essentially that of the normal population the first 5 to 10 years, and it's only, after that it drifts away a little bit. So it's just a remarkable change. And
I remember in the late 80s, a lady came to the emergency room and she had an infection because she was getting the new biologic, well, it was in the 90s, I think, the new biologic. Yeah, and she was like, oh my God, my life is so different.
Yeah.
Don't take this away from me. But they come, there's a price with those new medicines, the biologic group. Yeah. Tell me a little bit about that group in general.
The price is very high, for these medications, the biologic medications. And again, there's debates about where the costs come from, but I mean, an extraordinary amount of research goes into developing these drugs. The process by which you create these drugs is very complicated. And so there is an inherent cost there, and of course, people become cynical about it, and they say, the drug companies want to make the money in one thing or another. But I mean, it's costly to make these drugs. What we're hoping is that now with more of these drugs, we'll see the effects of some competition.
Right.
There are some medications that are in the biologic area that are called biosimilars. They're not generics, but they're similar, and they might have an influence on some of the cost. And that's, it just remains to be seen.
So tell me, what are the examples of the biologics that people are using? The earliest first biologic was?
Well, and it's important not to overlook this. If you have rheumatoid arthritis, okay, bona fide rheumatoid arthritis,
right,
there are very good non-biologic and fairly inexpensive medications.
That's
okay, hydroxychloroquine, Plaquenil, methotrexate, excellent. Sulfasalazine or sulfadine.
All old
there's
drugs
all drugs that can be used singly or in combination that can be very effective, and really the cost there is more in the $100 a month, hundreds of dollars a month, rather than the thousands of dollars a month that you see with the biologics. So
and they can do it like 50% of the time for rheumatoid.
Methotrexate works wonderfully. I mean, methotrexate, when we began using that in 1980, 81, and I was part of some of the early research when I was still in fellowship on methotrexate, and then, went back, and after I was in practice, went back the next year and saw how these people were doing on methotrexate. I was just stunned, and so I started using it in the spring of 1981 on rheumatoid arthritis patients, and it was remarkable. It wasn't actually technically approved by the FDA till '87. I mean, I had.
Is that you were on the cut? You were
350 patients on it by the time it was approved by the FDA. I mean, it literally, was a hugely effective drug, and we were afraid of it back then because we thought, we're going to cause cirrhosis, we're going to cause, Turns out a lot of that was ill-founded. We don't have to worry about it. The doses are so low.
Yeah.
So, and it's inexpensive. So it's really important that one not go directly to the biologics, okay, in probably 99% of the time. I mean, there are some exceptions where you might, make an exception to that rule, but you should try the more inexpensive, the standard medicines first. If you're going to move to biologics, then, those are categorized by what their action is. So there's what's called the anti-TNF factors, There's, I'm sure some of the viewers will be familiar with the names of Remicade, Enbrel, Humira, Cimzia, Simponi. Those are all of the anti-TNF, tumor necrosis factor, which has nothing to do with tumors. It's just a name of a factor that tends to be part of the promotion of the inflammatory disease.
Right.
But then there are a whole, there's a whole group of other ones now that have been developed from, Rituxan, Orencia. I mean, I don't want to go into all the names because there's a long list, and we'll undoubtedly leave some out. But there's a long list of them, and they're all the biologics. But they should be built on the foundation of the traditional standard medication treatment.
Start with those old treatments.
Right.
Some of those drugs used for chemotherapy or for cancer.
Oh yeah, that's part of what we learned over the years was that that autoimmune diseases, came from the immune system, which comes from certain cells types in your bloodstream,
right.
And cancer medicines kill some of those blood cells. Okay,
right.
And so if you kill off the blood cell that's making the factor that's making the disease go, maybe you can control it, and that's why some of these are good old-fashioned. Like methotrexate was originally developed in the '60s for leukemia in kids.
Right.
Okay, that was the original indication, and it was used for treating childhood leukemia for years. They were seeing some interesting things on kids that had some skin lesions that looked like, that was psoriasis. They were getting better, so they started in the '70s. They started testing it. They found out it was very effective in psoriasis. And of course, a lot of people with psoriasis have arthritis, and their arthritis was getting better, and that led to,
trial for other
maybe we should try this on just straightforward rheumatoid arthritis, and lo and behold, it changed the whole complexion of rheumatology.
So give me a list of the common rheumatologic diseases where they're primarily immune driven, not osteoarthritis,
right.
And not gout, which is crystalline, and not infectious gonorrhea, which is
right.
infectious.
Right.
What are the immune system driven?
Well, rheumatoid arthritis would be the classic. Then lupus,
right.
And all the variations. There's a number of variations on lupus.
Your body is turning against your own self.
Yeah, lupus is I sometimes will describe it to when I talk to lay people as it's like autoimmune means you're becoming immune to yourself. Okay, mm-hmm. And so lupus is just kind of this dysfunction in your immune system that wants to see parts of your tissues as being foreign, and so attacks them. And part of that is to rein that in and to control that. And that can show up in the skin, it can show up in the kidneys, it can show up in the brain, can show up in the joints, can show up. Lots of where.
But the lupus is where it turns against your own DNA, right, and RNA.
Well, it's an anti-DNA antibody. Okay, so it's seeking out that particular thing. It's not all of your DNA.
But a lot of our genetic material is attacked.
Yeah.
Well, what about rheumatoid? I mean, that's
rheumatoid
attacking.
it's thought of as an autoimmune disease, but there's a factor that's not getting cleared out somewhere along the line that's provoking this inflammation. So it's not really necessarily in a direct attack the way lupus is.
Okay. Before we go any further, I want to say that our discussion is driven by your questions. Give us a call. Call in your questions to 1-888-376-6225 or send us an email. So please give us your questions and get them in early. This is the great question answerer. Okay, so go on.
To continue with the immunologic stuff, ankylosing spondylitis, or the spondyloarthropathies, even though there is a genetic predisposition to this, the process itself is some type of an autoimmune inflammatory process. Scleroderma, which people have heard about, and there's all kinds of variations on scleroderma. Not the classic autoimmune disease, but there is some immunologic dysfunction that goes on that allows the fibrous tissue to
turn on. I mean, everything turns
the way it does.
Yeah, everything turns fibrotic.
And then, psoriasis and psoriatic arthritis. That's autoimmune. That's in that same genre. And then all the juvenile arthritis, all the kids with arthritis, and that can be anything. I mean, there's several different types of that. So, those are the big hitters as far as the autoimmune diseases.
Would you put giant cell arteritis in there, and would you also polymyalgia rheumatica? if I can make this thing work, I have questions. I can't make it work. It's not working.
The polymyalgia rheumatica, giant cell arteritis thing is, to some extent, it would be loosely categorized as an autoimmune, but it's really it's a different kind of dysfunction in the immune system that creates this, and again, these are complicated issues. To try to simplify it, polymyalgia rheumatica, poly, many, myalgia, muscle pain, rheumatica, rheumatism, stiffness, that kind of stuff. Okay, polymyalgia rheumatica is a broad sense of inflammation in joints that's reflected as muscle pain and muscle stiffness, okay? In that group, there are some that can go on to develop actual inflammation in blood vessels, and that's when they get the giant cell arteritis. And so there's a relationship there, but far and away more people have polymyalgia rheumatica than ever get giant cell arteritis.
Right.
But there's still a relationship there that you have to be aware of. And what we call PMR, polymyalgia rheumatica, is a very important diagnosis and disease for people to be aware of, because it tends to be in the northern or the upper plains areas more prominently than other areas.
We have it a lot here.
Yeah, we do.
Maybe it's because we grew.
And we should talk about that.
Yeah, we will. Dealing with arthritis can be painful and depressing, but one of the best things you can do is make sure you have a positive attitude.
When it first started, the pain, intense pain of the joints, I don't know exactly, but psoriatic is different than rheumatoid or some other arthritises. It affects the joints. You'll probably have I had some psoriasis spots on my skin, and I guess that's probably what diagnosed it. But I was very, very sore and achy, just extremely uncomfortable. Sometimes hard to get it going in the morning and get things done. But I never really had a lot of trouble in the morning, like getting out of bed or doing the daily things of dressing myself or anything like that. I was very fortunate that way. Cold weather bothered me somewhat, and being outside as a farmer, I had to deal with the cold. But my wife would always tell the story that I would come in after a long day and I would say I got on and off the tractor this many times. I counted the times I would get on and off, because the steps up to the tractor and steps down were always so hard to do, but just kept going. Luckily, I was self-employed. I was able to do my job. I had a lot of aches and pains, a lot of times that it wasn't much fun getting up in the morning, but I was able to. I was a dairy farmer for 28 years. So I used my hands and legs a lot, of course. Noticeably in my hands and my feet is where the arthritis has settled. And now I guess after all these years, it has settled down. I'm on no more arthritis medicines at all. I'm able to do my activities I want to do. I lead the life I want to lead. I'm very fortunate to do what I'm doing. Do not put off if you think you have any arthritis at all. Don't put it off. Get treatment. Try and get treatment right away. I know my daughter now we've talked, and she has some psoriasis issues, and now we've talked this week, and she's been a little bit sore in the morning, so I'm definitely making sure that she gets to a rheumatologist or gets referred to one, because there's wonderful medicine out there. There's a lot of things can help you. I've just been very fortunate that it ran its course, so to speak, for now. I just don't think you don't ever want to put it off going to find somebody to help you.
Well, I've never seen that gentleman's workplace. I've known him for a long time. He's got these weird formed hands from this psoriatic arthritis, but that's the picture of a functional man. He didn't let it get him down, and he got the right help in methotrexate for years, but now he's off of it. Yeah. How often do people, their rheumatologic disease kind of burn out?
Well, the majority of times it doesn't burn out, okay? But once you have control, then, and you don't see any sign of disease activity, I think then, and most rheumatologists at that point will begin to reduce the dose of the medicine, the frequency. And I've found probably over the years, I don't know, maybe 10 or 15, 20% of people who I can actually get off medication for a while gee, you know, they do fine for a while, and then, you know, if it comes back, I mean, the last visit, when we say, okay, no more medicine, don't need to see you anymore, is the minute you feel what it felt like before, you call us. I mean, you call us right now, because we got to get right back on this, okay? And very likely what worked will work again.
Yeah.
And so,
okay,
you know,
that's the question, because one of your patients, who is my patient, I sent him to Rapid City because of issues to you.
Right.
An electrician friend had psoriatic arthritis, was put on a biologic, I think Enbrel, and he's gotten off of it, and he called me today and he said, so I kind of want to get back on it because I'm feeling.
there you go. There you go.
There's the
He
answer.
made the right call.
He made the right call. We get him started again.
Right.
He needs to go, and you don't need to switch.
You don't. I mean, if it's exactly what it was before and everything is the same, I just pick it right up where I left off. Put on. I go with the full dose, though. I don't go with the lowest dose. I want them under control quickly.
Get him under
control. And then
control.
once they're under control, and then when you taper off, you know, if you go slowly. You go for a few months, and then you just say, forget about it. We don't need this anymore, and let's just see what happens. Yeah. And then if it comes back, you just jump on it again.
Okay. 59-year-old from Yankton asks about bromelain extract from pineapple. His chiropractor advised him to take it. Is there any scientific base for this?
You know, I don't know anything specific about bromelain or pineapple or whatever, but I know that there are a lot of what you would call alternative medicines, alternative supplements or whatever, you know, that are purported to fix arthritis, okay? And that's, you know, if you think about that, that's a pretty simplistic approach, okay? I mean, there are 200 or 300 different subclasses and types of arthritis, okay? And so I'm going to now give you, know, I mean, if in my mind I'm saying all arthritis is one thing and I'll take this supplement and it'll make it better, there's something wrong with that, okay? That's not, that does not make sense. Now, that doesn't mean that we can't look at things that could be helpful, all right? And you know, the case in point would be things like chondroitin and glucosamine, you know, where it was speculated on, and it's still not clear who that helps, but there seems to be some people that can help with certain kinds of osteoarthritis.
Right. And we can talk about osteoarthritis, but let's just do questions for a while.
Okay.
76-year-old man from Sioux Falls. What does doctor think of electromagnetic radio frequency treatment for lower back? Electromagnetic radio frequency. Have you heard of any of
Well, there's radio frequency ablation. You know, that I think that's probably what they're talking about.
Right.
Where, you know, our friend Dr. Cohen, you know, and can actually insert an electrode next to the nerve that's being irritated or whatever, and can make it sort of not work for a while, or ablate it or whatever, however that works, and that can be very effective for some people. I've had, you know, some people that would get good long-term results out of that, or they would get months of relief and then have to get it again. It doesn't work for everybody, but what does? I mean, you know, that's...
What about steroid injections? I mean, a lot of people do a lot. I mean, there are pain specialists that do a lot of back injections.
Yeah, you know, you know, I think that if you see a relatively acute impingement with some inflammation of a nerve, a steroid could turn that around. Okay, you could help that. But I think for the chronic back pain issues and chronic irritation with advanced degenerative changes and things like that, it would be temporary if at all helpful. Okay, and you know, steroids carry a little bit of a risk, side effect wise. Okay, I mean, you can trip somebody into, you know, you can whack out their diabetes control or one thing or another.
Well,
but,
that's the darn thing. The diabetes is sneaking around.
Well, I mean, if somebody's you know, on a couple diabetic meds or whatever, and they get an epidural steroid, all of a sudden their blood sugars are going crazy.
Out of whack.
Yeah.
What is your opinion on using over-the-counter NSAIDs, non-steroidal anti-inflammatory drugs like aspirin, Advil, Aleve? Explain what NSAIDs are and what their genetic names are, and what do you think about NSAIDs?
Names. Well, NSAIDs, non-steroidal anti-inflammatory drug. Okay, and you know, we'll start with aspirin. I mean, that would probably be the classic one, and it inhibits inflammation at certain doses. Okay. They also are interesting because they affect pain fibers, and so if, for example, you take aspirin and you have a headache or you have a sore arm from, raking or whatever you've been doing,
Right.
you take a couple of aspirin and you get some relief and you can go to sleep at night and everything.
Right.
That's just basically giving you pain relief. Same thing if you take a couple of Advil, or which is ibuprofen, or naproxen, which is the Aleve. It gives you short-term pain relief, all right? Now, if you take 12 aspirin a day on a regular basis, or 13 aspirin, or depending on what size you're on, then you get enough in your system, it becomes an anti-inflammatory. The problem with aspirin and an anti-inflammatory is that when you start taking that much aspirin, the side effects go crazy, okay? The irritation in the stomach, the bleeding, and all this kind of stuff. And that was where the ibuprofens of the world came in, and the naproxens and all these other non-steroidal anti-inflammatories, because you could get by with less medicine, less chemistry going on in your stomach, and less GI irritation, and you could still get that anti-inflammatory level. Now, are they totally safe? No. Okay, I mean, you and I have been around this block a time or two at the last 15 shows. Okay, yeah. So, but I still maintain, having grown up with the anti-inflammatory medicines. Okay, and that's where I trained, because that was
about all we had.
Yeah, that's it. Okay, and I was in medical school when ibuprofen came out, to show you how old I am, and I was a resident when naproxen came out. Okay, so I mean, those were huge advances at the time, and I always maintained that I could teach people how to take these medications in a safe way, and I think that translated to less side effects, less complications, and more efficacy over the years, because you have to explain to people how to take these medicines correctly.
Right.
And if they don't take them correctly, it's a recipe for disaster.
What's the correct way?
Well,
With food?
I mean, first of all, you never take them on an empty stomach, okay? You always have to eat, okay? Now, if you think about it, those pills, they've got to dissolve, okay? And what do they dissolve in? They don't dissolve in mashed up food. They dissolve in liquid, okay? So you've got to eat, so something's going and you're get juices going, and you've got food down there, and then you take a big glass of water with it, so you got something for it to dissolve in, and then it can, most of the time it'll be just fine. But if you notice things, if all of a sudden you say, gee, I'm waking up in the middle of the night with a stomach ache, or if I notice that I'm all of a sudden retaining fluid, my ankles are swelling, or all of a sudden my blood pressure is up, if I've already told you that those are the things you need to watch for, if you see that, you stop the medicine. Stop it. No harm, no foul. You stop the medicine and you call me, and we'll figure out something else.
Boom. Here's someone from Selby, 82 years of age, on ibuprofen. Heart and kidney doctor suggests that I get off of it. What's your opinion? So what is another option? I do like a baby aspirin twice a day or once a day for a polyp and colon cancer prevention.
Yeah. But you're not going to get anti-inflammatory.
No, but you're not going to get any arthritic pain.
Any arthritis help from that.
No,
okay?
But heart and kidney doctors want you off of it, I think probably because they want a baby aspirin to thin your blood, and they don't want you to mess with that by using doses of ibuprofen.
Well, I mean, they don't want, the thing is that if you've already lost some kidney function for whatever reason, hypertension, whatever it is, you don't want to take a risk of something that could add more
kidney trouble
to that. All right, and those drugs, if you don't have normal kidneys to begin with, can mean trouble. Even in people with normal kidneys, they can sometimes create problems.
Including Tylenol. Well, and the interesting thing is Tylenol has a rebound pain for headache, for example.
The Tylenol thing is not an anti-inflammatory, okay?
Right.
And the thing about Tylenol is that, there again, you and I grew up with Tylenol, okay? But Tylenol is one of those drugs that has an excellent safety profile until you hit a certain level, and then it goes crazy.
And it destroys your liver.
Immediately. But if you stay down here on the safe levels, 500 to 1,000, 1,500 milligrams in that, you'll never have a problem with Tylenol. Okay, you go to 2,500 to 3,000 milligrams, all of a sudden you can trip yourself into that.
Right, and one tablet is either 500 of its extra strength or it's 325. So you've got to realize that you want to keep that under
count tablets,
lower dose.
Do the math.
Yeah. Email, 82 years of age, in November got a diagnosis of polymyalgia, was on 30 milligrams of prednisone. It came back when I was down to 5. Now I'm on 20 for 3 months. I'm having a big problem with my eyes. Is there a chance I have giant cell arteritis, and how is it treated? So there's a lot the essay there. Is going to be about this coming up.
Here's the deal with polymyalgia rheumatica, okay? First of all, it tends to be in older people. So we were looking at people, you know, I think I could probably count on 2 fingers the number of people that I saw that were younger than 60 that had this. It happens, but it's very rare. Most of the time, late 60s, 70s, and 80s is where you'll see polymyalgia rheumatica. Right. And so if you think about that group, that's the group that already has got a little bit of wear and tear arthritis and aches and pains, and it's very easy for the doc to overlook there's something new's going on. So it's important that if this is a new stiffness and this is something different than you've ever had before, and you know, it's more in the muscles and not in the joints, you've got to point that out to your doc, okay? So first of all, you know, the doc's got to pick up on it. Second of all, it's usually associated with an elevated sedimentation rate, which is an index of inflammation. It's a blood test. And the third thing that's really important is that it responds almost miraculously to low dose prednisone. Right. Okay? Now, 30 milligrams to me, that's not low dose. Okay? I put people on, if I thought you had polymyalgia rheumatica right now, SED rate was 50, everything, you didn't have any kind of neurologic, any kind of visual things, nothing else, just a straightforward PMR, I would put you on 15 milligrams of prednisone with the expectation that within 24 to 96 hours, you're going to call me up and say, I feel like a new man, okay? You've unburdened me, okay? Right. If you don't respond to that, then
it's not
something's wrong, okay? And now on the other hand, if you came in and you had the same thing and you say, gee, I'm having pain when I chew, or I'm having some vision, then you've got to do the workup for giant arteritis. And it's temporal pain, high SED rates, and then you use, I mean, you don't mess around. You put people on 60, 80 milligrams of prednisone just to put the cap on right then.
Because you don't
right,
lose your
and then
vision.
do the biopsy, and you got a week or two, you can get the biopsy done, and if you've got giant arteritis, then you're in a whole different treatment category. So and the problem with the steroids is that with rheumatic diseases, people tend to get stuck. You know, if you use too much steroid to begin with for a routine problem, and then you try to taper it, you'll find people get stuck at these high doses. And that's why rheumatologists are always messing around with the 10s and the 12.5s and the 15s and the 1 milligram tablets and stuff, because we don't believe in dose packs, we don't believe in all that stuff for rheumatic disease, you know?
Okay, we got a minute left on this one. I used Enbrel per Dr. Engelbrecht's direction for most of 10 years. In April 2014, I stopped taking the Enbrel due to the fact that I was going to have back surgery in August, so it was decided that it would be best for the immune system that I'd stop it. I had some complication after surgery, so I never started using it again. I'm now getting lots of pain in my neck and rib cage and back, and this is the question, like the psoriatic arthritis. And you'd say go back to the Enbrel.
The thing is, you know, if you know, neck and back pain isn't typical for rheumatoid arthritis, though, so it doesn't quite fit. Okay, I mean, if you're on Enbrel for rheumatoid arthritis ought to be little joints, symmetric, you know, hands, wrists, ankles, feet.
I think this was psoriatic arthritis.
Could have been spondylitis, maybe. I don't know. Could have been spondylitis.
Spondylitis.
Yeah, I mean, you know, but there again, if it's the same symptoms coming back that you took before, then whatever the diagnosis is. But yeah, if it's spondylitis, then that would make sense.
If you're lucky enough to have healthy joints right now, there are simple exercises you can do to maintain mobility and function and avoid the pain and disability associated with, especially, osteoarthritis.
Now, when a person has arthritis, there's many different types of arthritis. And even when we don't have arthritis, our philosophy is keep moving. When we become sedentary, we lose muscle mass, we lose bone density, our cardiac system doesn't work as well, our respiratory system isn't as efficient, our gastrointestinal system doesn't work as well. There's many things that happen when we become sedentary and we just sit all day. So, therefore, my focus and my main phrase is we must keep moving. Now that means a lot of different things to a lot of different people, but there are some very simple things you can do to keep yourself moving and keep yourself strong and stable. So today I'm going to show you a couple basic exercises, and the first one we're going to do is what's called a heel and toe raise. So in a standing position, I'd recommend holding onto something for balance. Raise up on those toes as high as you can and hold for a second. And come back on those heels and lift your toes up as high as you can for a second. heel up, and then toes up. Now what's crucial about this exercise is that this is very functional for things like walking. That's what you do when you walk. You lift your toes up, you advance your leg, hit your heel down, you push off. So you lift up, and you push off as you walk, you lift your toes up as you are advancing forward. There's some very good research that looks at the loss of the ability to lift your toes up. We call that a foot drop. We see that very acute in things like a stroke. A person can't lift their foot up. But as time goes by, if you lose range of motion and mobility, you lose the ability to lift your toes up, you have more of a chance of falling. So therefore, we work on raise up the heels up nice and high, lift the toes up nice and high. So doing 10 repetitions of each every day would be wonderful. The movement of sitting to standing is going to have you focused. Now you can use a standard chair, and you can use your arm rests, and we get really good. You don't need to use them, but just basically go from sitting up to standing, and then back down. And we don't want to plop. We want to go up. And what we don't want to do is just plop, because that could hurt your back. So it's important that we go up, and then we come down. Balance is a skill that you can learn, and you can work on and improve. But just like any skill or any sport or activity, if you don't work on it, you're not ever going to get better at it. So there's many different ways to work on balance, but we're going to focus just on the very most simple, basic, fundamental, straightforward exercise. Holding onto a table or holding on something stable, just stand on one leg. Now, if you're just starting with this exercise, you got to hold on to something here. So we got to work and stabilize and just hold on to something here. Now, when you get really good, you can stand without holding on to anything. And when you get really good, you can stand, brush your teeth, comb your hair, and really work on your control. Balance is a skill. If you don't work on it, it's going to diminish. It's very important that you keep moving, no matter what your diagnosis is, especially if you have arthritis. If it's osteoarthritis, if it's rheumatoid arthritis, keep those joints moving. For example, your hands need to keep moving. Open and close those hands. Keep playing the piano. Keep using your hands. The old saying, if you don't use it, you lose it, it's true. So it's very important that no matter what situation you're in, that you find some type of activity level that you can participate with. If it's simple activities at home, if it's going to the gym to work out, if it's going outside for a nice long walk. Keep moving, keep moving, keep moving.
Now, there's a guy I lean on all the time. Chuck McCullough is a fabulous physical therapist. I mean, do you use the PT departments?
Physical therapy, I mean, I am a huge believer in physical therapy, and you know, I think that we could, you know, we can maintain so much function with the help of good physical therapy advice and the good OT, occupational therapy advice. And you know, I'm convinced with early osteoarthritis of the knee, you know, that if you can get in there with the right exercises and the right program of leg strengthening, you can change the outcome of that process. I mean, I think we could really reduce the number of total knees that need to be done and those kinds of things if you just get there early enough, so that you don't end up with a leg that wastes away, the muscles waste away, the joint becomes increasingly unstable, forms more bone spurs and hurts more, and then, you know, then all you can do is replace it.
And then when you replace it, you don't have any muscles for
Well, yeah,
it to
you know,
work.
even if you, let's just say the knee is, there's no question you have to replace this knee, okay,
Yeah.
it's shot, all right? The best thing you can do in advance of that is to have somebody sit down with a physical therapist and learn some strengthening exercises, so that when they put the new knee in, you got muscle that can make that thing work. Otherwise, you got to rehabilitate the joint, you got to rehabilitate the muscles, you got to do everything at one time. If you've got a good, strong leg from the physical therapy before the surgery, it makes all the difference in the world in outcome.
There was a guy I took care of who had a frozen knee, right? So he walked with a straight frozen knee, right? And I said, gee, I'd love to have an orthopedist, you know, get you a new knee. And the orthopedist said to me, there's no muscle. You can't make it, he'd just fall right to the ground. Right. He needs to have a frozen knee in which to function. You've got to have muscles for that knee to work.
Yeah.
So that's the point. When do you go to a total knee? I mean, before I ask anything, we need to do questions, but...
Well, I mean, the total knee, I mean, you know, it's pretty obvious when you have osteoarthritis in the knee, and the knee is shot, and you've tried all the other things, the medications or whatever, and it's just getting worse. I mean, people know intuitively it's time to do the knee. Now, some people, it's an interesting thing, will have oftentimes bilateral, though both knees are involved. And they'll say, well, if I'm going to do one, let's do them both at the same time. I generally recommend not doing that.
Oh,
okay,
really?
I have said many, many times where somebody say, find the worst knee, do the worst knee, rehabilitate that leg, do that knee, and you'll be amazed at how much better the other knee is once you get something you can rely on again.
Really?
And I've had people go years and years without having to have the other one done.
Wow.
And the complications and the potential downside of doing both knees is, again, if you're not the picture of health otherwise, it's not a good thing to do. So.
Okay. That's an important question for them to hear. 69-year-old man has rheumatoid arthritis and bumps on his hand. Can they operate to help his problem? Bumps on the hand.
Well, bumps on the hands could be rheumatoid nodules, or it could be, it's just hard to say what the bumps are. Generally, the sort
ganglion cyst, maybe?
No, I doubt it. Not with rheumatoid arthritis, but it's a cyst of some kind. It's a rheumatoid nodule. They're kind of soft, rubbery feeling things, as opposed to an osteoarthritis lump, which is usually rock hard. Okay, and so that would probably be the thing. As
do you operate on that, or you just turn off
well,
the rheumatoid?
the problem, you can operate on them. If they get in the way, they can operate and take them out, but you know what the problem is? They come back.
Yeah.
And
until you turn off the rheumatoid arthritis.
Well, even when you turn off the rheumatoid arthritis, if they've had bad nodules, sometimes they still come back.
Oh, really?
Yeah.
Wow. A woman asked if a blood test comes back with a positive creatinine kinase with a measurement of 400, could this be a factor that causes her muscle aches?
Well, the creatinine kinase is a muscle enzyme, okay? And if you get any kind of a process that attacks muscle, whether it's a statin drug, okay, which can cause muscle pain, can make the enzymes go up, or an autoimmune disease, a polymyositis, a lesser known one, but still very important, that can make the creatinine go up. And usually that's in the thousands, though, okay?
Right.
That's not in the hundreds. And then, by the way, 400 is probably normal for some people, too, okay?
Oh, really?
Just because the lab test says normal is between 80 and 180,
doesn't mean that
400, So if somebody had an elevated CPK or creatinine kinase and had absolutely no symptoms, I just bumped into it accidentally, what do? You don't work it up, okay? You don't do anything. Take a history, there's nothing wrong, they're fine, okay? Sometimes you get some crazy runner that goes out and runs a lot.
Oh, is that right?
And they'll make their CPK go up, yeah,
I think
if they
today
run
my
too far.
CPK
But anyway, what you do then is you just recheck it. You just recheck it and you see. And I had some people that were sent to me for high CPKs over the years, 600, 700, 800, and I would follow them for years, and there was nothing wrong with them. I just come in, check it, it's still the same. That's what your normal is.
Do you have real problems? Have you seen real problems from statin drugs, cholesterol reducing drugs?
Yeah. I would say, not so. And I think there's a little more of awareness now that could be a problem. And the thing is, it's not a problem for 80% of the people. It's only the 20% that get the problem. So, 4 out of 5 people can take them just fine, all right? But if you begin having muscle pain and stiffness, weakness, anything like that when you're on a statin, that ought to be the first thing they should look at. Stop
it's a $5 to $10 billion industry in this country every year. So there are a lot of people taking statins.
But they're so effective.
85-year-old woman, what's the difference between arthritis and rheumatism? Quickly.
Arthritis, well, there isn't such a thing as rheumatism, really. Rheumatism is an old term that just means my joints are achy, okay? Arthritis means there's something going on with the joint, and that may be one joint, or it may represent a whole body of disease.
So broader disease.
Yeah, rheumatism is old.
Rheumatism, old name. Woman from Aberdeen wondering if prednisone is effective to help lupus.
Yes, it
yes
depends.
Is the answer.
The thing is that prednisone is kind of the common denominator of all of the treatment approaches to lupus. Prednisone is not a cure. Prednisone helps you control the inflammation. Prednisone, when we use them in autoimmune diseases, is not necessarily the end game. But if I have somebody that's this inflamed, if I can do something short term to get the inflammation down and then think about what I'm going to put in next to control it, I would prefer to use steroids only for a short period of time. Now, sometimes you find out you get down so low and you can't get down any lower, but that's...
Right. 74-year-old man with pain, weakness with weather Does weather really change arthritis?
Yeah,
And
you know,
does it tell you
been
what?
talked about for a long time, and you know, some people will hypothesize that it's because inside the joint capsule, inside the joint, when the atmospheric pressure changes, everything internally has to change, and that you have this capsule around these joints,
Yeah.
and so that takes a while. And so if it's inflamed, it takes a while longer, and that's why you get stiffness with weather changes. Right. And you know, I mean, I kind of believe it. I've had a lot of people tell me that.
I kind of believe it too.
Yeah.
30 seconds, psoriasis on arms and legs takes methotrexate. Would that help my son's psoriasis? Does methotrexate help?
Methotrexate's very effective for psoriasis, and you know.
You just have to monitor because it can cause.
Oh, you got to monitor it. It's an important medicine, but it's inexpensive. Okay, look at the cost of that versus a biologic.
And now for the winner of tonight's Prairie Doc quiz question. When morning stiffness lasts more than an hour, there is something more than osteoarthritis going on. You should get in and be seen by your doctor. True or false? Jim?
Absolutely true.
The answer is true. It was Mary Moser of Sioux Falls who answered the question correctly. Thank you, Mary, for participating, and a book will be in the mail to you soon. Do you have any, what about morning stiffness? What does that tell you? Rheumatoid arthritis?
No,
anything?
it tells you inflammation. That there's something that's, when you get that, it doesn't matter whether it's polymyalgia rheumatica, whether it's lupus, rheumatoid arthritis, whatever it is, if you've got inflammation and you rest and you don't move around, those inflamed areas tend to gel. And so when you then wake up and you start to move, you gotta break that loose, and that's what that stiffness is. But it's more protracted in the inflammatory diseases. Everybody, as they get a little older, gets a little stiffness in the morning and do a little stretching and one thing and another. But this is unusually long, and it's really an important thing. I mean, if you have stiffness that lasts that long, you need to be checked out.
Yeah. Hot showers helps.
Hot shower, you know.
10 seconds.
Yeah, I should, you know, I have what I, you know, I maybe shouldn't say this, but I have what I tell the students is my hot shower test. If somebody comes in, and not a leading question, but they tell me just on their own, hot shower gets me going, they got significant stiffness.
We'll be right back after this.
As your baby grows, there are new surprises and adventures every day. With each new milestone, remember, immunizations are safe and one of the best ways to protect against serious diseases, especially between birth and age 5.
Now that my grandson Henry has reached his first birthday and our granddaughter Stella has arrived, we're making sure that they stay on their immunization schedules.
Schedule your children's immunizations today, for baby's sake.
How you doing? I asked as I walked into the room. Mrs. X was an 80-something-year-old widow, generally active and happy, living in her own home with her dog and with family nearby. Her response this morning, however, was not so good. That darn old Arthur has been visiting over this last month and he just won't leave, she replied. In fact, it's getting worse. The new discomfort was a symmetrical neck, shoulder, and hip stiffness, resulting in trouble getting out of a chair, climbing stairs, and combing her hair. I can't sleep at night, and then I'm just so stiff in the morning, she said. Thinking that this might represent a fancy name condition that commonly afflicts the elderly called polymyalgia rheumatica, or PMR, I had the laboratory draw an inflammation marker called erythrocyte sedimentation rate, or SED rate. Making sure this isn't a vision-destroying condition called giant cell arteritis, I asked her if she had any change of vision, pain in the temple regions of the head, or pain with chewing. She said no. It's important to ask about these symptoms because blindness can be prevented if giant cell arteritis is diagnosed. There were no temple pains or chewing symptoms, but her SED rate was sky high, which along with her story confirmed my suspicions of PMR. This is one of those wondrous diagnoses about which we can make a huge difference. And so we treated her with a daily 10 milligram low-dose prednisone to be dropped slowly later. When I saw her 3 weeks later, she was back to her usual self, working in her yard, smiling easily, and giving me back all sorts of fun guff. PMR occurs more often in people of Northern European extraction, and we should expect 50 cases per 100,000, or maybe 15 to 25 new cases in the Brookings and surrounding area every year. It happens a bit more frequently in women than men, almost never before the age of 50, with most cases starting around the age of 70 or 80. We don't know why PMR develops, but suspect it follows a certain kind of viral infection in a genetically predisposed individual. Some experts believe that PMR and giant cell arteritis are simply different levels of severity of the same disease, and both can be successfully treated once diagnosed. So if you start noticing terrible morning neck, shoulder, and hip stiffness, then you might greatly benefit by a visit to your doctor. Earlier in the show, we visited with Chuck McCullough about exercises to stay mobile. Chuck was also our guest this week on the Prairie Doc radio show that we do each Wednesday. There's a lot of additional information on our website, www.prairiedoc.org. In fact, we have a lot of additional information and advice on many subjects that you can access whenever it's convenient for you. You can even view past television programs or listen to our radio shows. Please take a moment to visit and sample the variety of resources we have there for you. If you're traveling or have friends or family anywhere in the world, our On Call with the Prairie Doc website can be accessed. There you can view the program live Thursday nights at 7 o'clock Central Standard Time and call in your questions, or watch us on the radio live Wednesdays at 9:30 in the morning Central Time. Again, that's all on our website. I sincerely want to thank our great guest, Dr. Jim Engelbrecht, for joining us. It's always a good and lively discussion when he's here. Thank you, Jim. Now on to our flu season update. As they say on Twitter, OMG, the rate of influenza has taken off in South Dakota, and it's now considered widespread in this state. In the last week of reporting, 102 new confirmed cases of influenza were reported. That brings us 293 confirmed cases cumulative so far this season. That means that over a third of the total cases have occurred in the last couple weeks. There have been 3 deaths from influenza this season. So what can you do? If you have a compromised lung function, COPD, emphysema, whatever, it could be a good idea to get the flu shot if you haven't already. I just gave one to a patient the other day. They're available and could still help. If you're otherwise healthy, you might take your chances if you haven't gotten the shot this season, but remember, next year when you're deciding about getting vaccinated. So thank you again for sharing this time from all of us here at On Call with the Prairie Doc. Until next time, stay healthy out there, people.
Like cousins growing up in different states, urban and rural healthcare are much the same, but different. Rural medicine, next time, On Call with the Prairie Doc.
Hello and welcome to On Call with the Prairie Doc After Hours. We had many great questions submitted beyond what we could answer during the broadcast portion of our show. Let's get started. A 78-year-old man from Sioux Falls has Parkinson's. I also have aches and pains. Are the two related? Can I go to a doctor like you and get prescribed something that'll help?
They can be related, but they really are different entities in terms of autoimmune disease and Parkinson's disease, and they can complicate each other. And I think that it really takes 2 people working together, a Parkinson's specialist, neurologist that knows what movement disorders and Parkinson's is, working with a rheumatologist to try to come up with the right regimen. Because to fix one problem and not the other or manage one without the other. It just wouldn't work.
Right. I always worry about polymyalgia rheumatica and that Parkinson's.
It's terrible, concern. But that's why, you have blood tests like SED rate and things like that, which, so.
Get a SED rate. 68-year-old man from Aberdeen. RS and RA blood tests were sky high. What's the significance of this? RS and RA. Rheumatoid arthritis, the RA.
I bet it's RF, maybe.
RF,
rheumatoid factor. Well, rheumatoid factor is just an immune, what we call an immunoglobulin. It's just an immune substance that tends to be present when people have rheumatoid arthritis. But it also can show up.
Lupus.
Well, lupus, but even with age, normal people. Okay, if you look at the age 75 and greater, totally normal. Draw rheumatoid factors and you'll find 20% of people have some rheumatoid factor, okay? And it's just because they collected IgM over the years because they've been exposed to a lot of things, okay? But when you get high levels, that's kind of a red flag, all right? High levels are not, they're usually associated with something going on.
Right.
And so that would be, there's ways to refine that and look at that.
But mostly the diagnosis of rheumatoid arthritis is from
the clinical
examination.
The rheumatoid factor is helpful, but then, there is what we call rheumatoid factor negative rheumatoid arthritis. Yeah. So,
a 68-year-old woman from Harrisburg, how does one know they have Sjogren's syndrome? Is this an autoimmune disease?
It is autoimmune disease, and it's, we didn't mention it in the big group because it's a small number of people that have it. It's complicated because there is an autoimmune disease called Sjogren's disease, Sjogren's syndrome, which involves an immunologic response, which you can do a blood test for, and there's certain characteristics of the salivary glands, and you can biopsy and see if they have all that, and that's the real Sjogren's syndrome. Then you have dry eyes and dry mouth, okay,
right.
And that's just all over the place. And that's not real Sjogren's syndrome. So, that's dry eyes and dry mouth, and then there's Sjogren's syndrome, and you have to have somebody that can separate that out.
There's a lot of dry eyes and dry mouth.
And meds cause it, and aging causes it, and we have more dry eyes and dry mouth in Rapid City than you do in Brookings because it's drier out there.
Yeah. And you get it when you're old.
Yeah.
75-year-old woman from Brandon, is lupus genetic, and how do you test for it?
The answer is yes, it is genetic,
always.
Yeah. Unless it's a drug-induced lupus or something like that, but bona fide idiopathic, systemic lupus erythematosus. There was a beautiful study where they looked at discordant twins and dizygotic twins and monozygotic twins with lupus. Okay, and if you had the monozygotic identical twins, they had the same incidence of lupus. If one got it, the other one had a high chance of getting it. And if you had dizygotic twins, there was no relationship there. So, that sort of said, okay, it's genetic. How you test for it, it's really, a lot of it is how somebody presents, what the history is, what their exam's like. But there are some very good specific blood tests. The DNA antibodies, you can do the ANA test, but DNA antibodies are specific. There's a whole host of things.
Got to know what you're doing. But it's the clinical picture that is the most
clinical
important.
picture gets you going. But the thing is, none of these things are the blood tests such that you should just go to the mall and set up a booth and test everybody, and we'll find everybody with lupus. It doesn't work like that. Okay.
Would you explain dermatomyositis?
Yeah, dermatomyositis is a form of muscle inflammation. There's a condition called polymyositis, which just means that many muscles are inflamed. But then there's a specific subset of that, which is dermato, which means it involves the skin. And so it's an autoimmune process where muscle tissue is being attacked, and for whatever reason, the skin is being attacked. And
so they have heliotropes in the eyes and dotted patches.
They get this sort of purplish discoloration in their eyes. They get these papules on their knuckles. They get kind of breakdown thick hands. This is what's called mechanic's hands. That's what because you've been beaten up on your hands and those are all some of the typical things. The thing is that it has to be worked up by somebody that knows what they're doing, because there are different associations of dermatomyositis, one being with some forms of cancer. And so you have to know, is this pure dermatomyositis? Does this represent a reaction that's telling me that there's really some tumor developing someplace? And somebody's got to think that through. You just can't,
I've seen cases of what polymyalgia rheumatica, quote unquote, responded to fairly high doses of steroids, and it turned out not to be polymyalgia rheumatica. It was polymyositis and cancer.
Right, yeah.
Woman from Pierre, does ginger root have any significance in therapy?
It's like we talked about with the pineapple deal and everything. I mean, those things are all speculative. There's no outcome science to it. The people that promote it, you hear about these things. I mean, you can, if it sounds too good to be true when it's being promoted, But the other thing is that there's why some of this stuff works, placebo effect.
Yeah.
I mean,
that's a powerful thing.
Oh, it's powerful. And what I've told people is, the placebo effect is even much stronger the more money you pay for the placebo.
Oh, yeah. it goes up.
So $1 placebo doesn't work nearly as well as a $100 placebo.
Oh. 81-year-old from Sioux Center, Iowa, arthritis and neuropathy connected. Neuropathy. And is there any medication for it?
Well, yes and no, okay? For the typical peripheral neuropathy, there's really no association with any kind of arthritis.
That's stocking glove. That's the
that's the
numbness in your hands
and the feet and that kind of stuff. But there are nerve dysfunctions that are associated with different rheumatic diseases. There's that can cause specific kinds of nerve things, which is different than a peripheral neuropathy. Okay. So, it's kind of it's a complicated issue, but just to automatically tie neuropathy with arthritis, it's not something most people would do.
Make sure the B12 and the TSH is checked. Woman says, I have pain from my shoulder to my elbow on both sides of my body. The weather affects it a little as well. Is this arthritis or muscle pain? Could be polymyalgia rheumatica.
Yeah. Again, doesn't say how old she is. Doesn't say how old she is.
No.
Diffuse muscle pain, okay? And again, it's stiffness and pain. It's not weakness.
Right.
Okay. People with polymyositis don't present with pain. Now let's not get confused. Polymyalgia rheumatica and polymyositis, two different things. Okay.
Right.
Polymyositis, they present with weakness. Polymyalgia rheumatica, pain. It hurts, stiff, and it's usually around, either on, usually both sides of the shoulders, and occasionally in the hips and the, so.
Right. I'd love to get a good night's sleep, great joint pain in my hips, reposition every 15 minutes. I'm losing the question. What happened to it? So what about sleep I use a pillow between my legs sometimes. I guess I have moderate osteoarthritis. I think the greater problem is nerve related to the pain, goes down my thigh. Doctor has basically offered to help deal with pain meds. Are there other choices? I take Motrin pretty much around the clock. Haven't slept well for years. I'm so tired. Sleep.
Yeah, it's an important thing, and with all of the autoimmune diseases, fatigue is a big thing, and fatigue can be inherent in the disease, and it can also be because people don't rest well. So I mean, it can be, a multifactorial thing. But the positioning at night with the pillow and that, I mean, if that works, that's helpful.
What do you do to help people with sleep?
Sometimes, well, I like, she says she's on ibuprofen around the clock or whatever, but sometimes in that situation, just 500 milligrams of Tylenol at bedtime. Even though you've taken it, it works fine with ibuprofen, but just a little something in addition, a 500 milligram Tylenol at bedtime would be fine.
Trazodone, I like trazodone. You like that?
I like trazodone. It's been around for a long time, and you don't have to take very much of it. You take the 50 milligram, break it in half. Take 25 milligrams of trazodone. Sometimes works wonderful. I really like the muscle relaxant cyclobenzaprine. I know it got some bad press from nursing home stuff, but if you know what you're doing, that is a wonderful medicine. Even a half of one sometimes will get you some sleep. So I think that they're...
You ever use amitriptyline?
Yeah, I've used that too. But again, the dose has got to be small.
Right.
You know, we're not talking about, you know, these are
150.
antidepressant medicines. This has got nothing to do with depression. This is sleep modification.
Yeah.
This is prolonging non-REM sleep. And so that's, you know.
So this person from Iowa called about rheumatoid arthritis, lupus, and fibromyalgia. How different is fibromyalgia from those other things?
It's very different in that it's a widespread pain syndrome. I mean, you could if you say fibromyalgia, I'd just say widespread pain syndrome, and I don't know why. Okay, I mean, you just heard all over, and I don't know why. All right, and there's certain characteristics of that. Sometimes there is an underlying disease, sometimes like rheumatoid arthritis, because you're dealing with chronic pain all the time, all of a sudden it sort of explodes into widespread pain. Sometimes somebody has had a whiplash and they got a neck pain in the neck, and then all of a sudden it explodes to widespread pain. And then sometimes it just there, it's widespread pain. And if you have certain tender areas, you know, there's, you know, you can classify it, and you can kind of confirm the diagnosis, and there's diagnostic criteria.
But
the treatment is very difficult. And you know, I thought that I could be effective in treating it and working with people, but you get to the point where there's only so many hours in the day, and I have people who their lives are threatened by lupus or rheumatoid or complications of that, and I just got to the point where I just couldn't take care of fibromyalgia because it takes a lot of time.
And our treatment's not very effective.
And people, you know, you're horribly miserable at times, but you're generally never disabled by it. You can usually work through it, and your lifespan is normal. So, you know, there again, pain management, exercise, to some extent. I think exercise is a good thing with it.
And amitriptyline at night.
Amitriptyline at night, and that's been shown to be helpful.
Yeah.
I mean, that's been shown in studies.
58-year-old woman is on methotrexate for 2 years for rheumatoid arthritis, but she often misses work. She still has a great deal of pain. Should she change medication?
So that's
a very important question.
It's a very important question. So there's two things here. First of all, you know, is she taking the methotrexate at the right dose? All right. If you're underdosing it, you're always going to fall short. So the next question is, are you dosing appropriately? There's also a vitamin, folic acid, that we have everybody take, which we initially thought was kind of protective for side effects.
Right.
And it turns out that it actually helps the methotrexate work.
Really?
So it's very important to take the folic acid.
I didn't know that.
Yeah, yeah. I mean, there's actually a plus there. Okay.
Wow.
So it's important that you take it right, that you take the
folic acid with it.
And then the other thing is, does it still show that you've got a lot of inflammation in your system? Are your joints still swollen? Is your sed rate still up, and you're just not getting there? And that's, if you're not getting there and you're on the full dose, you know, you sometimes can add a medicine in like Plaquenil or sulfasalazine to the methotrexate. Sometimes you can do 2 or 3 drugs even to do that. Or that could set the stage for then adding an Enbrel or Humira or something like that.
Wow. Really quickly now, we're going to run through a bunch. Ginkgo biloba, what do you think of that? Compared to aspirin?
You know, as far as I know, it's not an anti-inflammatory, and I don't have any opinion on.
Rapid City, psoriasis and arthritis, taking anti-inflammatory agent. However, he's allergic, has had an allergic reaction to medication. What should you do for alternative? If he's got psoriasis and arthritis, he needs to see you or see a rheumatologist.
He needs to see a rheumatologist, because there's a lot that can be done there.
A lot more than just arthritis pills, non-steroidals. Have fibromyalgia, rheumatoid, hands and shoulders, and we just talked about fibromyalgia. Diet, any diet thoughts about? Okay. Viruses causing autoimmune diseases. What are the causes of autoimmune?
Well, you know, the answer is that we think that there's something that sets this off, and it could be a virus, it could be a viral particle. I mean, it just, you know, here's an interesting little thing. If you look at people that have hepatitis C, okay, viral infection,
right.
okay, there's a significant number of them after a period of years. They don't get the liver disease necessarily, but they get an autoimmune disease. They get what looks like rheumatoid arthritis, or they get what looks like lupus, and so there we have an example of a virus that sets up housekeeping, and then it affects your immune system in such a way that you get. And the interesting thing is, a lot of times, if you treat the hepatitis C, the autoimmune thing goes away.
Really?
Really.
That's interesting. I mean, I didn't know the hepatitis C connection. Yeah. I have arthritis, spinal stenosis, and bursitis. My internal medicine doctor has me on tramadol, acetaminophen. Any comments?
And what was the spinal stenosis?
It's spinal stenosis, bursitis, arthritis, is on tramadol with Tylenol. Should I be seeing a physical medicine specialist soon?
Yeah, you know, physical medicine and rehab would be good. Physical therapist even might be helpful. You know, in that medicine, there's no anti-inflammatory.
You got Tylenol and tramadol.
Yeah, right. Neither one. They're both just pain pills, okay? I mean, and they're good. There's nothing wrong with them. And together, they're even better, okay? Right. I mean, a tramadol and Tylenol, I think that's a good combination. But, you know, you could mix in some anti-inflammatory in there. You could mix in some Aleve or some ibuprofen or something like that, and you could still use that.
My husband's been told by 2 surgeons there's nothing can be done for his arthritis of the back. Are there any meds that can help the pain? Back pain and if the surgeon said no, anything that you do for people with chronic back pain, it's a tough deal.
Well, yeah, it is. It is, and you know, you look at it and you try to understand it, and you know, there's different things and different opinions that people have of what they can do and what they can't do, and it's you know, you try to sort it out as best you can, and you know, like you know, we were talking about Dr. Cohen and his, you know, the radio frequency. A lot of people do radio frequency ablation, and it certainly is something that can be tried, and
right.
It can be helpful. If it doesn't work, no harm, no foul. Okay, right. It didn't help. Okay, but you know, I had some people with a variety of different kinds of back pain, from spondylitis to work, and it was just nerve pain. I controlled their disease, but I couldn't get over it, and the radio frequency ablation was enormously helpful to some of those people.
Gabapentin, you use much for the nerve pain?
Yeah, for some nerve pain. Yeah, gabapentin.
Someone asked about temporal arteritis. It's the same as we talked earlier about giant cell arteritis.
Right. Giant cell arteritis, temporal arteritis, the same. And the key is you have to do a biopsy.
Biopsy of the temporal artery. Right. Tracheobronchiomalacia. His lungs collapse, makes it very hard for him to breathe. Is there anything that we can help? And is it related to autoimmune disease?
Well, yeah, you know, there's a condition called relapsing polychondritis.
Right.
That can affect any cartilage. There's, you know, sometimes it's just very limited. Sometimes it can be diffuse, and you can end up actually with collapse of the trachea to the point where you can't breathe and you can't support it. And you know, I mean, people actually die from it. So, you know, there again, there's more to that question than
Then we can answer here. Do you treat it with this chronic relapsing chondromalacia with anti-inflammatories?
You try to use some steroids to cool it off to begin with, and then you just kind of create things to try. You know, I've got some people. You know, and again, you know, in you know, probably 18,000 charts is what I ended up with that I had charts on people at the end of my practice. Yeah. Okay. I could probably count on 2 hands, maybe I could count on 1 hand the number of cases of relapsing polychondritis. One of them passed away from tracheal involvement and everything like that. A couple of them, though, have done very well. I've got them on hydroxychloroquine and a little bit of prednisone when they flare. So you create things, you create regimens, you know.
Boils associated with arthritis? Somebody from Sioux Falls, an 88-year-old.
You know, not really, no.
A woman from Watertown having polymyalgia rheumatica, giant cell arteritis. Is there another treatment besides prednisone?
Yeah, you know, the thing is that the prednisone can cool this thing off very quickly, and then you should very slowly taper the prednisone. I would say the most common mistake I see that primary care does is they try to taper too fast. You've got to go slow. The thing is, though, that there are some ways. If you get down to a point and you can't go, you can use some things like methotrexate. There's been some interesting work on the biologics, the Actemra, the IL-6 inhibitor, been shown to have an effect on that. So I mean, that whole area of giant cell arteritis, you know, there are ways to reduce the steroids and even eliminate the steroids. I had some people that I could get them off steroids and then have them on methotrexate for a year, and then when the disease finally burned out, I could take them off the methotrexate.
Okay. And we have an 81-year-old woman from Lake Norden. She has arthritis. How does she know if she's developed polymyalgia rheumatica, and how would it be diagnosed? This is the last question.
She's got rheumatoid already?
She has arthritis.
Okay,
How
so
does
we
she
don't
know?
So she's probably got
This is a
osteoarthritis.
polymyalgia.
The
Yeah.
thing is
81.
the thing is
Lake
that
Norden.
the thing is that
And they don't complain.
no,
These
I
people
know.
from Lake
I mean,
Norden,
so this is
stoic.
this is a serious deal.
Yeah, it is.
So, so the deal is that if it's more muscular, more soft tissue stiffness and
Yeah.
aching than actual joint aching,
Yeah.
then it should be checked out because it could be polymyalgia rheumatica.
All right, and primarily that shoulder stiffness, neck stiffness.
The biceps, the triceps, the deltoids, all,
showing it. Great. Well, thank you so much for being our guest and tolerating all these questions. Thank you for joining us on our website. We appreciate all your questions and the opportunity to answer them. Until next time, from all of us here at On Call with the Prairie Doc, stay healthy out there, people. Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
and by
The South Dakota Foundation for Medical Care, an organization working with the state's healthcare community to improve quality of care as part of the Great Plains Quality Innovation Network. Additional funding is provided by
Aberdeen Asthma and Allergy, Avera Heart Hospital, Brookings Health System, Dakota Allergy and Asthma, Dakotacare, Orthopedic Institute, Physicians Care, Sanford Clinic Community Service Committee, South Dakota State Medical Association, Swiftel Communications, and Vance Thompson Vision.
Closed captioning for On Call with the Prairie Doc is provided by
Avera, Brookings Health System, and Fishback Financial Corporation.